Hey everybody, this is John. Just going to do a quick Block 3 wrap up. First off, I want to congratulate all you guys for doing a fantastic job this block. Significant progress since the first two blocks. You guys are definitely able to dissect the material, go through the material a whole lot better, and being able to find the information of pertinence and applying that into some clinical reasoning components, which is basically the plan. So you guys are doing fantastic. Keep it up. Quick little reminder what you guys pretty much are doing super fast. Just remember to cite AMA. A couple guys are still having issues with that. And then when you're posting your article, remember to either have a direct link to it or to download it so that everyone else is able to read it at that point. But otherwise, everything is doing fantastic. Keep it up. We're down to our last block, so we got to finish strong, right? So I'm going to go a little off base, a little off cuff here. This is my favorite article. It is super interesting, but has a lot of clinical component. At least I see a lot of this as well. So first off, author's name is Dr. Dye, who is a surgeon. Not exactly the most comforting name, right? And top it off, his brother is also one of the co-authors, so they're the Dye brothers. And title of the story is Conscious Neurosensory Mapping of the Internal Structures of the Human Knee Without Intra-Articular Anesthesia. So basically, these surgeons were having patients coming in, and they kept saying, man, it really hurts right where this portal is. How come? And they didn't really have a good answer. So their solution to that was they decided, I'm going to have somebody stick a probe inside my knee and start poking at a whole bunch of stuff, and we're going to see how bad it hurts. Spoiler, all three of the people involved were guys, if that makes a difference. This was also the time before Sci-Hub. So I actually emailed Dr. Dye 10-ish years ago, something like that, and he gave me some behind the scenes to it and basically said they flipped a coin. Loser was the doctor. Loser was the patient, winner was the doctor. And they literally just did that, went inside with a probe and started poking around. So they did both knees without any anesthesia. And then they rated the pain as 0 to 4, 0 being nothing, 4 being severe. And then they also had a modifier. So A meant that it was very specific and very local, or B being that it had poor localization. So depending on where they were poking, it ranged anywhere from a 0 on the patellar articular cartilage to very local and severe on the anterior synovium, fat pad, and joint capsule. The interesting part is that the sensation from the cruciate ligaments range anywhere from a 1 to a 2B. So it was mild and vague at the mid portion, and as it approached its insertion sites, it became still vague but increased in pain. And then similar to the meniscal component as well. So it went from 1, so mild and vague at the inner rim, to moderate and vague near the margin of the capsule. So here's some pictures. So you can kind of see that anterior component. And when I was talking to him, he basically said it was like if he could rank it a 10, he'd rank it a 10 on a 4-point scale. He said it was severe. So even compared to 3 to 4, he said it was the 3 to 4 was bad, but the 4A was really, really bad. So you can kind of see all that anterior synovium, that fat pad area. And so that's always kind of one that people don't necessarily take into account when they're looking at anterior knee pain. So a lot of times if you take that distal patella and you apply a little bit of pressure, you'll see these two little pockets on either side, medial and lateral, kind of pop out. Those are your fat pads. And they are highly sensitive with nociceptors, pain receptors. So people can come in with irritation of that fat pad, which can decrease patellar mobility primarily inferiorly, which then has an effect on quad activation as well. So you'll notice decreased quad strength, poor patellar mobility, and then pain with palpation over either medial or lateral fat pad. There typically also will be some lateral hip weakness also. So I see this a ton in the clinic. Like if they're not post-op, this is probably one of the more common things is they'll come in with this either anterior medial or lateral fat pad pain. So basically the moral of the story is that anterior synovial fluid, the fat pad, the capsule were exquisitely sensitive to the mechanical loading of the probe. And then the sensation experience was similar. Probing of the cruciates did not result in accurate spatial localization, so it was very vague. So that's why a lot of times people will come in with an ACL tear, MCL tear, or a meniscal tear, and they're very vague on where they say it hurts. They're like, it kind of hurts here, and then they're kind of covering their whole knee in that general area. So that is their explanation as to why some of that poor localization occurs from that. So it's only an N of 1, but it's a super interesting article if you guys want to, and it's really short. I think it's only maybe 3 or 4 pages, so check it out. So highlights of the week, treatment of ACL tears according to Froebel. Surgery must answer. It's just like anything else, depends. Sometimes it is, sometimes not. I've figured out that maybe not as much as we're using it. And then performance-based testing. This can get a little tricky and interesting. Nothing standardized. And then the majority of patients who have ACL don't return to their prior competitive levels. Same thing back in the day, 15 years ago, I took a George Davies course, and literally he called his functional testing or performance-based testing the puke test, where it was literally you'd have to complete 10 running tasks, which were roughly 30 feet both ways, would be 60 feet, and then you had to go in under 2 minutes, and if you could do that, you were good. That's all. That was only his test. So now it's gotten a whole lot more specific with Powers and Melbourne and Santa Monica and all those guys with some of their performance-based testing. And then with, let's go back with, Beischer, this also just came out last week, I believe, found that return to sport after 9 months resulted in a 7-fold increase in re-tearing their ACL. So she was recommending even longer than 9-month hiatus. And they found that it also did not depend on muscle strength. So you could have super strong muscles and it still didn't make a difference. NEOA, you're basically going to use manual and exercise. And then for patellofemoral, think regional. However, with Matt's article or Matt's post this week, also discussed that there can be a psychosocial component as well, which is interesting. Or, even what we just talked about with patellofemoral, you can also have some fat pad irritation as well. So I wanted to go on to my little soapbox as to why I love PT, and I ran out of space, so I just came up with this many. So obviously it's the coolest and the best job around. We can make a significant immediate difference without passive techniques, so no meds, no injections. You get to see substantial progress objectively and subjectively. There's so many facets to PT between ortho, neuro, peds, acute care, academia, etc. We are the musculoskeletal experts. People will remember you forever. I personally don't have favorite body parts, just favorite patients. And literally, I have fun all day. So I don't go to work. I just go to a place and hang out with people and try to get them feeling better. So going back to letter F, a couple years ago, I had a 25-year-old rugby player with a knee dislocation. So not patellar, but full-fledged knee. And this is actually the picture of time that it happened. I remember at one point treating him, he said, one way or another, I will remember you for the rest of my life. It'll either be for positive or for negative. And at that point, it hit me like a ton of bricks going, holy cow, I need to step up my game. So after this happened, he had vascular surgery 6 hours later. The next day, he was taken by ambulance 3 hours away, where an external fixator was placed, and he had 4-compartment fasciotomy. 8 weeks later, he had ACL, PCL, and MCL reconstruction, at which point is when I started seeing him. So the next couple pictures are from his fasciotomies. So if you are squeamish, I'll let you know when you can start looking. So close your eyes. So there's right away after it happened. There's one of the fasciotomies. You can see how that tissue already is kind of darker. Definitely losing some blood at that point. And then the next one. So yeah, this was medial, lateral. Here's where it's definitely starting to pink up. This one's lateral. Here's back on our medial side again. And that medial side just never fully got where we wanted it to get. So long story short, he ended up doing a below-knee amputation. However, he was totally okay with it, and he has since had a super positive attitude. I was on him right away, making sure mentally he was solid, he was in a good place, and he has been. And since then, he's actually been participating in a lot of sporting events, and actually currently is looking to become a rugby official. So he's actually been participating back in rugby, just non-contact at this point. So he has been rocking it. So this was actually this week. So I've only seen him maybe 6 or 7 times post amputation. And he is, as you can see, doing pretty decent. So this is one that definitely could have taken a turn, and he could have become super negative, super depressed, super woe is me. And he said, nope, I'm going to take this and I'm going to make the best out of it. So he has so much more function since then, and he is just stoked. He is just happy, which makes me super happy too. So more of the stories, keep that passion going. Remember why you wanted to become a PT. Remember all those patients that stand out and why. Don't get caught up in the mundane. We tend to get into our routines, and remember every once in a while, just take a step back. Don't lose sight on how important your guys' jobs are. So it was super awesome to read all your guys' why you love PT. That was great, especially in kind of this funk that we've all been in with COVID stuff. So on to our last block, ankle and foot. We'll finish up the patient case. Make sure to let me know if you have any questions. Finish strong, and you guys are rocking it, so keep it up. Otherwise, thanks.